Get ready for a no BS approach to health and fitness. This is NBS Fitness Radio.
All right, welcome back to MBS Fitness. I am here with Natalie Narrow. Natalie is a nurse practitioner whose kind of focus point is hormones. And is that hormones specifically for women?
Actually, I do both. I actually started in men's hormones, and I saw how amazing it was for them. It really changed their life, and there wasn't a whole lot of options out there for women. So that's whenever I really got focused on women's health.
Awesome. Okay. What kind of sent you down that path? What attracted you to the endocrine side of the medical space?
I just saw so many people suffering. Again, men and women. Men are pretty easy to change. You just sprinkle a little testosterone on them and they come alive.
Yeah.
But as a woman myself, I was experiencing myself a lot of issues hormonally, and I felt like it was hormones, and I kept going down the path of seeing an endocrinologist, seeing my OBGYN, and they kept telling me nothing was wrong. But innately, I knew that there was something going on. And I was working in the men's hormone industry. And I thought, well, if this can change a man's life, why would hormones not change a woman's life as well? And I was tired of hearing women tell me that they've gone to other providers, they've seen other physicians, and they keep getting told it's just part of aging, it's just part of life, and they're just struggle through it. I just don't believe that that's a good answer.
What were the issues that you saw yourself, that you've seen in other women? Like, what are the indicators that something might be off?
It's a vast variety of things. Typically, anything a woman can complain about can come back to hormones.
Okay.
So it can start with weight gain, hair loss, excess hair growth in places we don't want it,
Yeah.
headaches, migraines, irregular cycles or no cycles, hot flashes, night sweats, poor sleep, bone loss, muscle loss. It is fatigue, brain fog, joint pain. I mean, everything that I have found most major issues for most patients, autoimmune issues, it all comes back to hormones. Hormones are the central system of our body that really control everything.
Yeah. Is there an age at which this seems to hit the majority of females? Because assuming to feel off, you had to have felt on at some point, right? At some point, your hormones were regulating correctly. You weren't experiencing these things, and now I am, and I'm aware of this difference. Is there an age at which that tends to, or like common age? You see that?
So a lot of times women are told perimenopause starts in your 40s. However, I'm seeing it start sooner and sooner in younger women. It started for me in my mid 30s, but I am seeing really bad hormonal imbalances in women as young as 17 years old today. The majority, though, to answer your question, I would say would be between 40 and 55.
Gotcha. So essentially, you may have like kind of two categories. You have like perimenopausal, like
Mhm.
this is a function of your body changing as you age. But
Yes.
then you might have 17-year-old hormone issues, which may not be related to just that.
Yeah.
Um,
And honestly, that comes from a lot of endocrine disruptors that we come into contact with every day, especially women, health and beauty products, things like deodorant, or even the strip on our razor can have PFAs in it. The fluoride in toothpaste, the fluoride in our water system. Our food is absolute garbage today. And so I'm seeing a lot of this in young women.
yeah, I was gonna ask, like, what's the trigger? What's causing these issues to happen early, and also to happen to the magnitude that they're happening? Because women have been going through hormones since the beginning of time. It does appear, as men have been aging since the beginning of time, but it does appear that the impact of modern day life is having a negative impact on our
Absolutely.
hormones to a greater degree in an earlier age.
And as a man, I'm sure you would agree that, or if you have any experience with testosterone, you know that men's testosterone, the normal values have consistently gone down in the last 20 years drastically.
Yeah.
Whenever I first started in men's hormones, the range at the time was somewhere between 800 and 1500. Now it's 200 to 1000. That doesn't make sense to me. So again, I try to, in my practice, make things make sense. But yes, to answer your question, it is a lot of crap food. It is a toxic environment. It is the stress load we put on ourselves that really cause the majority of health issues. But the impact typically starts with our hormones. And it's hard to clean up your life. It's hard to go out and eat fully organic. It's hard to go out and make sure everything is free and clear and free of chemicals. And so, I try to guide my patients in not only just balancing their hormones, but giving them the correct information as to how to navigate the world today, because the rules are not the same as they were 20 years ago.
Yeah. Yeah, 100%. Yeah, and you go like, okay, what's the chicken or the egg? Because there's a level of just lifestyle change would help impact your hormones, but like your hormone status makes that lifestyle change very difficult. If you're gonna give like top 5, hey, here's 5 biggest changes you can make. Let's go. We'll leave pharmaceutical change out of it for just a second. But the top 5 lifestyle changes. These are things to do to lessen the impact of the environment on your hormones.
First of all, just having a good spiritual background, having a foundation of really getting to, whether that's meditation, whether that's having a church relationship, whether that's yoga or whatever you can do to soften the blow in your brain of everything you take in daily. That's number 1. Number 2, getting good sleep. Sleep is so underrated and so undervalued in our society today. Most women that come to me, they say, I sleep pretty well. But whenever I dig into it a little bit more, they might sleep 2 hours for the first 2 hours that they are asleep. And then they wake up and then they sleep for another 3 hours. It's very interrupted. It's not consistent. I don't know that they actually enter into any REM sleep. So sleep is number 2. 3, definitely food. I kind of toggle between would it be food or exercise, but even with exercise, if you eat like crap, you're not going to get the results. So 3, eating more organic, really paying attention to what you put in your body. And that actually starts with mastication, or how you chew your food. You can eat the best diet in the world, but if you're eating it in 5 minutes flat, you're not giving your body time to produce the enzymes that you need to digest and absorb and get the nutrients you need from that food.
I would say if you're eating the right types of food, you're gonna have to chew it.
Yeah, exactly. You can't just swallow. And that's going to help with how much you eat too. So that would be number 3. Number 4, I would say exercise, of course. And it depends on the type of exercise. Making sure that you do, women are always, I can't name the times women go, well, I don't like to lift heavy weights because I don't want to look all muscly. Okay, but you need weight bearing exercises to maintain good bone health. And, it's going to look better on you too, I feel like.
My statement to that is always like, fair enough. I don't want that for you either. Why don't we do this? Let's train for 3 months. Mm-hmm. And if at any point you're like, okay, I'm looking too muscularly, we'll adjust.
Absolutely.
Let's see if we even get close to that first. And then we'll
exactly. Because I'd rather have more muscle than fat. And then number 5 is joy. Like you can't replace vitamin J. And that's whatever that is for you. Getting out, spending time with your family, finding balance in life. is truly important.
Love it. So, like we use a framework we call sleep, eat, move, manage, and
Mhm.
so it's sleep, how you sleep, how's your nutrition, eat, how's your movement, how's your training, and manage, how's your mental health. And if when you went through that, it kind of hits all four of those.
Mhm.
And I think what's important about like what sticks out to me when I hear that is, and the same things, the things that build your health in one area build your health in all areas. And a lot of times people will want to pull a stuff over $100 bills to pick up pennies, and they'll be like, they're looking for what's kind of like the quick easy thing, and they're like, I'm gonna start taking vitamin D. Like, no, like vitamin D is good. I'm not like that's a good thing to
Yeah.
take. Or I'm gonna totally revamp my diet, and like that's a good thing. But if our ping pong back and forth is like, well, I'm gonna eat only organic meat, but then I'm gonna have ice cream every night.
Yeah.
you know, like
There's no
the
balance there.
yeah, like the foundational thing is like, man, the biggest ROI you could probably get is sleeping better,
Hmm.
and man, and getting your life in a way that helps you sleep better, which is going to help you have more energy. You're going to be less drained. You're going to have less stress. That'll help you have more energy to engage with other people, and you'll experience more joy, and you'll have time to, um, you'll feel refreshed and have time to then do things that bring you joy and feel more refreshed, like, and want to eat better food, and not trying to hit your dopamine button with bad food, and you'll feel like you can go exercise. It's like these are all the kind of foundational
Have to do a
components.
little bit of everything.
Yeah, yeah. But it's just like the way you kind of went through it, I liked, because I do think having, I tell people, is having a strong foundation for why, which I say is like stewardship of your body. So if I have a strong foundation of why, stewardship of my body, which makes me say, you know what, I'm going to make sure I sleep good tonight. I'm going to I'm going to do things necessary to get a good night's sleep so that tomorrow I can go exercise.
Hmm.
Right. And I'm going to eat so that or tomorrow I'll go eat good. So that'll fuel my body and I can exercise well, and I can engage and do the things that I like to do with the people I like to do it with. And I got to go and do that, like, foundational piece. So I'm glad
Absolutely.
you said that. I'm glad you said that stuff, and that people can kind of take away, like, hey, like, these are the things we know work.
Absolutely. And the other thing is, and you actually hit on something about, stepping over $100 bills to pick up pennies. Another very important thing that I do in my consults is to really set expectations for patients and say, look, I can make you feel better, but it's not going to be tomorrow. It may not be in 2 weeks. I might have, I use baseball as an analogy. Sometimes you step up to the plate, or I step up to the plate and I knock a home run straight out of the gate, and I can figure it out quick. And I just add a little sprinkle of this and a dash of that, and you feel amazing. And then sometimes I just get you out of the dugout. Maybe I only get you to first base. And so but it's all about what they do too. And I really try to educate patients on, I'm going to give you all the information, inspiration, and education. It's what you do with it from there. I can balance your hormones, but there's still 180 other steps that you have to take to truly feel good. Um,
Yeah, yeah.
yes, hormones are very essential and very impactful. Um, but it still takes the work on the patient's part as well.
Yeah, yeah, yeah. It's like I can fix it. You had, I say, you got kind of five broken pillars or whatever it is. I can fix the hormone pillar, but if you don't fix the other, sleep, nutrition, exercise, mindset, then like you're still going to have a rocky foundation.
Absolutely.
I'll kind of give you like a quick background on myself, but um, in my early 20s, I get into like powerlifting and bodybuilding, and with that came like excessive hormone usage,
Mhm.
and essentially, like, my wife and I decided to have kids, and I produced no viable sperm. So I got off everything completely, and I was on a lot. So I
Mhm.
went from a lot to zero. I think my level, at the bottom. It was like 112 or something.
Yeah.
And I went on a Clomid regimen, and that got me fertile.
Mm-hmm.
But
But it didn't make you feel good.
well,
Yeah.
my testosterone never came back up. And I mean,
And
I did all the stuff, and the guy was like, "Look, dude, you did steroids for 10 plus years. Like that's kind of what happens, right?"
yeah.
So, so I had all my kids, and now I was done having kids. I was like, okay, now I'm ready to go back and get my hormone levels kind of rebalanced. Now the thing was, is like I exercise, train, and stuff. I did all this stuff the whole time,
Mm-hmm.
and I felt okay.
Mm-hmm.
Like I felt okay. I didn't feel great. I knew what feeling great felt like. I didn't feel great, but I felt okay. When I got my hormone levels back, I was like, I feel great again.
Yeah.
But what I've realized is like, if you're doing all the stuff, you're doing all the right things from habit, lifestyle standpoint, and you have hormones are off, you'll feel okay, but you won't
Yeah.
feel great.
Yeah.
If you get your hormones balanced and you don't do any of the lifestyle stuff, you'll feel okay, but you won't feel great.
Absolutely. It goes both ways. You got to do both. So yeah, that's definitely a important, like you said, a pillar with my patients is I definitely tell them, look, they'll come back. I'm looking at their labs. They look perfect now. And they go, I still don't feel good. Well, then what are we doing? What haven't we hit? And I'll look at everything. It's not just sex hormones. I look at thyroid hormones. I look at adrenal hormones. I look at pancreatic hormones because all the hormones do a dance. They're all, and you want them to do the same dance. They're all in orchestra with one another, and I kind of associate it to a pinball machine. That little ball, you set it off and it just pings off everything, and that's how hormones react. So, your hormones control your gut health, your hormones control your metabolic rate, your hormones control your sleep. So, we got to get it all balanced.
Love it. So let's kind of focus in on perimenopause and menopause. What is perimenopause?
And I tell patients I hate these words and terms. I think doctors throw out insurance companies made diagnoses codes for insurance coverage. And so perimenopause, yes, we have to use these words. Perimenopause literally means around menopause. And so women come to me and they go, my doctor told me I'm in perimenopause. And they really don't know what that means. And it actually just means, well, you're around menopause. So that can start happening at 35, that can start happening at 45, but I just think of it as a very slow decline in how you feel. A lot of women will come to me and go, I just thought it was part of life. Like, yeah, I can't sleep very good, but I know I'm stressed and I got a lot of workload on me and my family life is disrupted. And, I have sick parents that I'm taking care of and I don't exercise as much as I used to. And I don't eat as well as I used to. And they start feeling that slow decline. And then they come to me and they go, I literally woke up this morning, looked in the mirror, and I didn't recognize the person in front of me. And so that's kind of what I consider perimenopause. But
can I ask you this?
yes.
What is the clinical definition of menopause? I mean, is it a hormonal level, like an estrogen
Menopause,
level?
if you Google menopause, the definition comes up as a female who has not had a cycle in 12 months. And that's it. That's it.
Okay.
I mean, that is the clinical definition. So, but I've met 35-year-olds that haven't had a cycle in 12 months because of hormonal imbalances, not because they were menopausal. And it could mean that they had a surgical menopause, they had a hysterectomy, and even at a young age, and now they're clinically in menopause. So they just don't make hormones anymore. They don't make enough hormones. They can't make enough hormones to produce a cycle.
Okay, so let's kind of let's clarify that. The female menstrual cycle. What are the hormones that are triggering that? What's kind of that dance? And then maybe that gives us a clear indication of like what menopause is, and then what perimenopause is from a true hormonal standpoint.
So that is a quite loaded question, but I'll try to simplify.
Okay.
Women have like, men and women, we have the same hormones. We just have them in different amounts. So for women, we have, probably 6, 8, 10 major sex hormones. But the three that I focus on the most are progesterone, estradiol, and testosterone.
Yeah.
So our ovaries produce these hormones, and progesterone just helps a woman's cycle for the most. I mean, it means literally pro-pregnancy,
Yeah.
pro-gestation, pro-pregnancy. So it is the hormone that we need as women to keep a pregnancy. And so it gets really high during pregnancy. And if you've ever talked to a pregnant woman that loves being pregnant, it's because they feel fabulous during pregnancy
Yeah.
for the most part. And it's because their progesterone is perfect. And then they have the baby and their progesterone is completely depleted and they go through postpartum. And I've always been kind of shocked at why most OBGYNs don't go, hey, let's put you on some progesterone, because they're going to feel better. They're going to sleep better, even with a baby. And so progesterone helps sleep cycles. It helps your menstrual cycles. It helps the thickening of the uterine lining so it doesn't get so a lot of women who go through endometriosis and hysterectomies, they're progesterone deficient. And again, if we go back to talking about endocrine disruptors, when we started, the endocrine disruptors, what they're doing is making our estrogen climb, and it's getting so high, and our progesterone cannot compensate for it. So women do end up with heavier cycles and fibroids and endometriosis and difficulty getting pregnant. And it excess estrogen causes bloating and headaches and migraines and just feelings of dread. So it is about balance. Go ahead.
All right. So if you could draw like a line, so in a woman's cycle, we see kind of progesterone here, and then it starts to climb as they ovulate. Is that correct?
Yes.
And then they'd have their period, and then it would come back down.
Mm-hmm. And then estrogen tends to climb. They kind of go together, but in various amounts,
Yeah. And it's that balance between progesterone and estrogen that makes for a natural cycle.
Yes.
Where a woman feels the way that they should. And you're saying because of these hormone disruptors, there's these chemicals within our food and then within our environment that act like or stimulate estrogen so that so these things are supposed to be in tandem and kind of working together, and they get out of whack. Estrogen is too high, progesterone is where it needs to be, but because estrogen is too high, we have these negative effects.
Absolutely. And again, I'm seeing that more and more in younger women.
And so we see like that kind of climb and decline of progesterone and estrogen throughout a woman's 28-day cycle. And then what does testosterone do? Is it steady? Is it supposed to be steady the whole time, or does it flow?
I tell women all the time, so this is funny. We have a normal reference range, just like you do for men, for women, for testosterone. Through the lab company we draw it, it's 6 to 82. Now, the average number, and I've drawn labs on as women or young girls as young as like 13 years old, all the way up. I think the oldest patient I've ever drawn a lab on for hormones is 87. And the average number across the board is 24. I've only seen a few occurrences where it might have been greater than 31 naturally. So testosterone stays very flatline, baseline. Yeah. There's not a whole lot of movement there. And I've had women who've been, physique models and just super, they're in the gym all the time and they're trying to get their testosterone up naturally. And I might see it go to 32 and it started at 20, so it's not moving a whole lot and you're just not going to see that.
Do they feel it? I mean, cause that's a 30% increase, but can they tell that?
Mm-mm. Because most women, so I will tell you, most women feel good. And this is, of course, just out of experience. You're not going to find any research on this. But just based on experience, most women feel better between 80 to 250. I like to keep mine around 250.
Your testosterone levels.
Yes.
Yeah. Okay. Well, I think it's interesting that people are not quite aware of is that women actually produce more testosterone than they do estrogen.
Sometimes.
Yeah. I mean, ideally, yeah.
Yeah.
Okay. So this, we see that kind of what like its ideal is supposed to look like, and when someone's going through perimenopause, now what are you seeing in their hormones that indicates to you like, oh, something's going on different here?
So in perimenopause, I see their progesterone being almost zero. It's usually like
Okay.
0.2, optimal being greater than 10.
Yeah.
So 0.2 is the lowest they'll even look at the lab. And then now, especially with perimenopause, I'm seeing estrogen numbers in the 500s. Now, even if you're not a math genius, you can take 0.2 and 500 and go, that does not sound balanced. And then, of course, their testosterone's in the 20s. So what I try to do is get their progesterone around 10 to even 30, and then get their estrogen to be around 80 to 100, maybe 150, and their testosterone at least 150, because that's balance. If you're the happiest patients I've found is their estrogen and testosterone are almost the same number.
Gotcha. Okay. Yeah. Okay. So, what I'm hearing is like a lot of these issues are from like sky high estrogen, a completely depleted, very low progesterone, and testosterone that's not non-existent. It's low.
It's just low. And it's also being muted by the estrogen. As you know, in men, if your estrogen gets too high while you're on testosterone, you're not going to feel good on your testosterone. You can't out compensate the estrogen.
Right. So then, the balance. So the balance, like, let's get your progesterone up. Let's get your testosterone up so it's balanced with the estrogen. Is there ever, what are you doing to bring down it? Are you trying to bring down estrogen?
Yes. So what I do to bring down estrogen is, first of all, progesterone ices the estrogen drive. So that is one way to do it. The other way is getting rid of bad estrogen. We need to metabolize that. So again, I'm looking at liver function. I'm looking at insulin resistance, because insulin resistance and estrogen have a very direct correlation. So if they're heavier and they have more fat cells, then obviously they're going to also produce more estrogen. So one thing I do is add a supplement called DIM, DIM. It's derived from broccoli. Broccoli has some great estrogenic metabolizing properties, and it just helps you metabolize bad estrogen. Another great source is ground flaxseed. I actually have patients add ground flaxseed to like a smoothie in the morning if they are fairly estrogen dominant. Because whenever you are naturally estrogen dominant, you're also setting yourself up for a lot of cancers. A lot of women get told, I can't take hormones because, there's a family history of breast cancer, or I had a nodule or something that got removed and they said it might've been estrogen positive. Well, it probably wasn't from any natural estrogen. It was probably from the birth control pills they were on for 20 years. It was probably from the fast food they ate for 25 years. It's probably from not working out. It's probably from not eating anything organic and being exposed to too many pesticides. So I try to educate patients on that as well, that the hormones that we deliver, first of all, we're trying to get your estrogen balanced, and balanced hormones should not produce any cancers.
Right. So have you seen it where someone who had a sky high estrogen, you bring their testosterone up, you're doing these things to bring their estrogen down, then they start exercising, they're eating right, they're doing all this stuff, and you see the estrogen like drop to a dramatic degree, and like, do you then have to bring the testosterone back down to kind of like balance with it? The testosterone's okay at that level.
That is very patient specific. So,
Okay.
and it has a lot to do with the side effects that testosterone can cause too.
Yeah.
Like I love my testosterone being 250, 300, but if I go too far, I mean, again, you're going to get very male properties. You're going to grow a beard,
Yeah.
possibly,
Yeah.
and more, and you start losing hair. And that's where
Yeah.
women get nervous, whenever they start seeing
Yeah.
hair loss on the head, you get the male pattern
Yeah.
baldness.
Yeah.
So I do try, it's more about educating the patient and letting them tell me when they are
Yeah.
at the right dose.
Yeah. So like, hey, let's kind of see what the right dose is for you, where the positive effects are in this sweet
Outweigh the
spot.
side effects. Yeah.
Yeah, but the negative effects are not showing up. Yeah, okay. That makes sense.
Mhm.
So so you at what point do you start administering this? So someone comes in, say like this typical average female, she's maybe 45, she's starting to kind of experience some of this stuff. And you're saying she's not menopausal, she's still having
Mhm.
cycles,
Mhm.
but I'm feeling these things. And at that point, you say, hey, like let's start getting you on some hormone treatment now to address this stuff.
Absolutely.
Yeah.
Absolutely. So women come in and, I do the full consult on them, but I really I get a full list of their symptoms. I have them fill out a symptom questionnaire. Are they having night sweats? Are they sleeping? Are they constipated, which is a common issue for us. I look at all, are they irritable, bloated? I look at all the symptoms, and then testosterone is a really great starter
Okay.
because pick a woman up pretty quick.
Yeah.
Especially whenever we hit our mid 40s, we're definitely not feeling ourselves. We're very insecure sometimes. And then, we might even be having marital issues because we're not as vibrant and vivacious feeling as we used to be. And that plays a big role in our relationships. And so women come in, and I start them on a very low dose of testosterone to start with, because I have no idea how they're going to metabolize it.
Yeah.
I take into account what their estrogen is. And because I know testosterone can convert into estrogen, again, it's always safe to start small. And I tell a patient, the worst thing I'm going to do to you is nothing. If nothing
Yeah.
happens, it's okay. We can add more. So I typically do pellets. And a lot of women are very nervous about pellets, but it's a very quick, easy procedure. They dissolve, they're natural, and it gives us a very steady state as well. But I also,
Yeah.
go ahead.
Why do you do the pellets over a shot or a cream or foam, or like why pellets?
I mean, I do. Again, it's more patient specific. So I'm pretty good at reading a room. So if I feel the patient is very nervous about anything hormonal, I'm going to start them off with a cream because, and I tell them, look, you have complete control with this cream. If you don't like something about it, you stop it. It goes out of your system in 24 hours. It's really quick and easy to metabolize. So it's all about, if they want more control of that, then a cream would be better for them. If they some women who are more in the gym and really want to see results, they really like the injectables, and I'm fine with that too. We can do injectables with them. And then of course some women just want convenience and ease, and they heard their friend got a pellet and that's really all they needed. So it's patient specific.
Yeah. What do you prefer?
Well, that's a loaded question too. I've done all of them. And and I felt like injections work the best for me as far as energy and muscle mass. However, I do a pellet because it's better as far as side effects with injectables. And it's the same for men as it is for women. We get more acne, we get more facial hair as women with that. We do lose more hair on our head with injectables. So for pellets, women don't see the side effects as much.
And maybe let's explain like why that is. When you say cream, like explain to people, like when you're getting that cream, it's a very short ester that's going to cause a rise and fall. Like explain to them what the difference in testosterone
like how it's
Uh,
metabolized in the body.
Yeah, metabolization and then like delivery. Like, what's the difference between pellet shots
Mhm.
and cream?
So anything that I do is going to always be compounded and bioidentical. I don't typically like anything synthetic, just because our body knows the difference. You can't, our bodies are actually pretty smart. I have patients tell me all the time, oh, well, my body just rejects this. It's working against me. No, it's not. It's giving you warning signs.
Yeah.
And we just have to listen to our bodies. So, but I do like bioidenticals more. With creams, it is about how the delivery system can be, it's not as great because you have to put the cream on, you have to let it dry, it has to be fully absorbed. And that can be, if you have darker skin or thicker skin, it's not going to be absorbed as well. And then you have to move that cream around for it to be absorbed appropriately every single time you get it or give it to yourself. And so whenever we're going through this process, I see very inconsistent numbers, and they don't typically go up that much. It takes a lot of a higher dosage in a cream for it to really move your numbers. Again,
Yeah.
I say that in general, that is not across the board. Because I have some patients that do really well on cream, and more power to them if that's what they want. And they like it. And then with injectables, typically it's made in a cottonseed oil. Many compounded versions use a grapeseed oil, which is a little cleaner. The cottonseed oil can make the blood counts thicker. And so and men definitely deal with this more than women, but we still deal with it too, where it causes a secondary thrombocytopenia, which just means your blood is thick. And those women I have to tell, look, you want to go give blood every 3 months, and or we need to lower your dose, or maybe start you on an aspirin or something like that, because I don't want people walking around with thick blood either, because that can increase your risk for stroke and heart attack. And then with the pellets, they're very clean. They're made in a cholesterol. It dissolves over the course of 3 months. The cholesterol does not raise your actual cholesterol levels. It's just how your body knows how to break down the pellet. But it's they're all derived. The pellets are derived from yams, and the creams are as well.
Okay. Very cool. So to kind of summarize, creams, I would say maybe less invasive way of giving it,
less invasive, yes.
but it's a little less consistent
Mhm.
as far as like a delivery. Pellets, a little less schedule invasive, because it's like
Mhm.
one, and you get one to put in every 3 months. It's gonna kind of be a smoother kind of a dose there, and then the injectables potentially have a little more
Umph.
oomph in them, because you're getting kind of those bigger kind of peaks, and once you kind of get those peaks built out, but
Mhm.
with those
And
peaks, you also have
I actually dose those once weekly for women subcutaneously. So that way
okay, yeah,
they actually they can stay at higher levels and keep a very consistent ride, because what I did not say is the injectables, typically the half-life is 5 to 7 days. So
yeah.
you have to, make sure you're staying on it.
Why do you do the sub Q over the intramuscular?
For women, it's just a little less invasive. Uh,
Okay,
I mean,
it's just
and
easier shot to give.
it is an easier shot to
Okay,
give.
yeah, yeah,
And well,
that
and
makes sense.
also you can make it's easier to get that tiny of a dose, because women are using such micro doses. For guys, y'all can use a 3 ml syringe and fill that thing up and give it to yourself. For women, we're using like a tenth of that. Yeah.
Yeah, that makes sense. Okay, yeah, you can use a totally different syringe. Okay, so yeah, so like your kind of process is get them on testosterone first, and kind of get them that boost, begin feeling good, and then also I imagine there's a little bit of oh yeah, okay, now I can see what hormone therapy can do for me.
Yeah.
What's
And
next? Like
and I almost always add progesterone at bedtime.
okay,
Progesterone is
yeah,
natural ambien. So
yeah,
again, if I'm getting them to sleep, I'm telling you, I would say probably 9 out of 10 women do not sleep well. So
Right,
I
yeah, yeah.
start them on progesterone straight out of the gate at bedtime, and it's a very quick, it's called rapid relief. You know, they get that rapid relief and they come back to me 6 weeks later and they're like, oh my gosh, where has this been my whole life? So that's what I want to hear, you know. And if they go,
Yeah.
you know what, I feel better, I'm sleeping better, but I'm still not, I feel like there's more that we can do. Well, then we give them a little bit more testosterone, adjust that dose. Sometimes they need more progesterone. You know, we get boxed in as medical providers with, we're given, you know, a medication and they tell us this is how you're supposed to give it. But people are all innately different and their
Yeah.
metabolisms are all very different. So I've given as little doses of progesterone as 25 milligrams all the way to 800. So the same with testosterone, the same with estrogen. You know, I let the patient drive that conversation and match it with the numbers. So the numbers are a good guideline, but the patient's symptoms and what they tell me is way more beneficial to how I dose them.
And what it's, I like that you're saying, like, I treat my patients as individuals,
Mhm.
because if you think like how typical pharmaceuticals guidance is provided, they said we did this study with this many people and this was like the mean experience, and so we're going
Exactly.
to tell you to give things like that. And you're like, well, what about the people who were on the upper or lower end? It doesn't give you any guidance in there. So you're saying, like, I treat my patients like a patient and go, I'm going to treat you based off what you're telling me, what you're experiencing, what I'm also seeing in the numbers, and what I feel is like the best way to kind of navigate this versus boxing myself into a
Protocol.
medical protocol that was based off of like a single study that.
And you don't even, sometimes the group that they studied weren't even the patient that you're sitting in front of. So
Right. Yeah. There's like not even, it's not an accurate assessment of like that patient. Yeah. If it was done in 60-year-olds and your patient's 25, well, it's totally different.
yep.
Okay. So like perimenopause, someone comes in, I kind of deal with this stuff. Cool. Let's just start kind of treating it, seeing what works best. I feel good. This is great. I'm
Mhm.
happy. What happens to their hormones as they continue to age and progress up? And one question is just like, do they keep it? Does it push menopause back, or do they eventually find themselves
So
when they're like they continue to have cycles? Like,
so
does
it
that go?
can.
What happens?
Now
Yeah,
your body, your ovaries are going to give in whenever they're going to give in. They all have an expiration date, and typically I tell patients, when did your mom go through menopause? That's a great crystal ball for me to know that information. Sometimes, you know, if their mom had a hysterectomy, well, that tells me that you were born to have most likely really bad hormones your whole life too.
yeah,
So, but so well, I have a lot of patients that come in, they might not have been 12 months without a cycle. Let's say they've gone 8 and they've got 1 foot in the door of menopause. I'm very, you know, kitten gloves on giving them any type of estrogen at that point. I'll typically try like a topical cream or something low dose, because if they're having hot flashes, if they're having, you know, anxiety, that is symptomatic of low estrogen. So I can give them a little estrogen, but if I'm not going to just blast them with it, because I'll kick them
yeah,
straight back out the door of menopause. So I want
yeah,
them to get a little menopausal so I can treat it appropriately. But it's a battle that I deal with every day. Sometimes, you know, I'll get a patient who's perimenopausal about to walk in the door, I kick them right back out. And I base that off
yeah,
their follicular stimulating hormone. And of course, how long it's been since they've had a cycle. So if their follicular stimulating hormone is greater than 40, then that means they're typically in menopause. I want it to be 25 or less, because the less or the more I can reverse their follicular stimulating hormone, I'm actually pausing, if not reversing, the aging process. And whenever I tell women
yeah,
that, they're like, sign me up. That's what I want.
yeah.
So again, it's about balance. So I follow the patient's symptoms and I follow the labs. A lot of women, they don't even realize that they're, a lot of women feel like menopause is going to be a switch. Like they wake up one day and the menopause fairy came and sprinkled dust on them and now they're menopausal. But it's more of a slower process for most patients unless it was surgical. The other thing is it can be a switch for some patients, and that is almost a trauma to that person. As an old ER nurse, I saw women come in all the time. They thought they were having a heart attack. They were severely anxious. They're literally were having chest pains. I mean, they were having all the symptoms of a heart attack. We'd put them on an get an EKG on them, run labs on them, have them do a stress test, whatever, go through the full process. And then the ER doc would send them home with a Xanax because they were having a panic attack. And it was because the estrogen tanked so fast, they didn't realize that was a hot flash or an anxiety inducing hormonal issue.
Gotcha. So kind of coming back to that like hormone timeline, what you're kind of trying to do is perimenopause. Let's get the progesterone to a healthy level. Let's make sure our estrogen and testosterone are at this healthy level, and we're kind of cruising there. We're feeling good. But when menopause starts to take place, we start seeing that estrogen start to tank, and now we're getting the opposite effect. We once had our estrogen way too high. Now it's going way too low. And now we got to get it balanced back up there, kind of with that testosterone level again. So as we're starting to go through menopause, you're trying to ease the transition, but making sure their estrogen doesn't just drop off the deep end.
Yes.
But also not giving them so much that you kick them back out of menopause. So it's like you're really trying to like ease them through these different kind of hormonal changes. So when someone then goes through menopause officially, not having any cycles again, and then is that the point where okay, now we're kind of slowly kind of bring that estrogen back up to what that healthy level is.
Yes. And again, that it is very, I have to follow the symptoms because I don't want to give them a cycle again. Women that have gone 12 months without a cycle, if I make them bleed, they are not happy campers. They're like, oh my gosh, I don't
no.
Exactly. And it's very scary for them because they assume that now that they're in menopause that they should never have a cycle again. But I tell them, look, I give them all the information up front. If you start to have any bleeding or whatever, then that just means that I need to adjust the hormones again. I might need to pull back on estrogen, or I might need to increase progesterone. Those two hormones I have to duke it out with daily to make sure that I've got the patient on the right dose.
Here's a question that shows my lack of understanding of female cycles. Once a female, okay, so can a female start menopause yet still have viable eggs available? And then my second question is, once they've used all those viable eggs, can they still have a cycle?
Oh yeah. I mean, you can still have a cycle without any ovulation. But it's more about the uterine lining at that point. But, I can't accurately answer that question just because, I mean, Janet Jackson got pregnant at 51. So, I mean, it is a possibility. If you are having a regular cycle once a month, then yes, there's always a possibility that there's an egg somewhere. I don't do any testing. That's pretty extensive testing to get. But I mean, typically once their follicular stimulating hormone reaches a level that's greater than 40, you're in a fairly safe zone. I will never tell a patient though, please use a second form. If your husband doesn't have a vasectomy, let's have that conversation. And then some women, they might have even had an IUD, and let's say they've had it for 5 years and I'm pretty sure they're menopausal. That thing can last for 8. So I'm like, just keep it in there for another 3. Let's make sure we get you through menopause and then we can pull it later. So, again, it's very patient specific. So I have unintentionally got people pregnant.
So we kind of covered the perimenopause, menopause. We transition. We've gone through menopause. is it just continue kind of monitor those hormone levels and kind of take how the patient's feeling and just kind of cruise them through the rest of life? Yeah.
I mean, patients typically ask me, do I have to do this forever? I said, no, you don't have to do anything, but you're going to want to, because
Yeah.
again, testosterone and estrogen, the balance for us does the same thing for us as it does for men. And we want to categorize things as, well, this is a man's hormone, this is women's hormone. But think about it. Your hormones in balance help anxiety, depression, sleep, mood, feelings of well-being, increases muscle mass, decreases body fat. It helps you focus. It helps joint pain. It prevents other disease processes. So, it helps produce new bone. That's a big one. Women, when they hit 55, they get told, well, your hormones are gone. You need to go get your bone density scan. I mean, they don't tell men that, because y'all keep your hormones longer typically. So women go get a bone density scan. They go, oh, well, you have osteopenia, osteoporosis. Let's put you on calcium. Let's put you on this horrible medication that's going to cause brittle bones in 5 years. But the problem is progesterone creates new bone and estrogen breaks down old bone. We need that continuous cycle. Progesterone keeps breast from getting dense tissue. Progesterone keeps you from getting brain fog. Estrogen helps with brain fog too. Of course, it's all in balance. And so I explain to patients, no, you don't have to do anything. But if you want to maintain your breast, your bones, and your brains, then you might want to stay on hormones.
Yeah. Yeah. If you would like the hormones of a healthy younger person and the benefits that
Absolutely.
comes with that, like maybe you want to keep doing this. Would you recommend is there benefit to a female to say, well, I mean, again, if they go to their OBGYN every year, are they typically running hormones? No. So is there
Now,
benefit to saying,
so
hey, you should probably get your hormones checked on a yearly basis?
so this is the problem. And I came from an OBGYN background. Yes, a lot of times an OBGYN, if asked, they will say, yeah, let's run and see if you're menopausal. And then they say, yes, you're menopausal, or no, you're not. And that's it.
Yeah.
Most times.
I guess my thought is like, would it be beneficial to say, because from a male perspective, a lot of times we said, ideally you would have a yearly testosterone test to know where your trend line was, so that like if you hit 35, 40 and you start seeing it come down,
Do we need to
if
treat
you
it?
were if you were averaging 800, if you were like 800 the rest of the time and now you're 600,
Mhm.
though you're showing up as within the zone, you're like, I feel different and I just had a significant loss, let's treat that. So like, would you think there benefit for women to track that over their life as
A-
well?
And again, I have to say that depends, because if women were on birth control for the first
Oh yeah,
15,
yeah.
it's going to mask all their hormones. So that would be irrelevant. And then
Okay.
if they had I mean, there's so many different scenarios. So I'm not going to say it wouldn't be beneficial. However, ours are so dynamic. I mean, again, because we have menstrual cycles, it's sometimes, yeah, it's a roller coaster.
So you had
So
to check it at the exact same time every month. Yeah, okay. Every time you did it or whatever.
but
Yeah.
I would definitely say, if a woman is having increased anxiety and depression at any age, if they are feeling more fatigued than usual, if they are starting to gain weight from out of nowhere and they haven't changed anything, you really want to find somebody that understands, and their specialty is in hormones. And that's not
Yeah.
always an endocrinologist. An endocrinologist
Yeah.
means hormone doctor, but a lot of women will go to an endocrinologist and get maybe not so great information, or get veered into a wrong direction. So it really takes a hormone specialist, somebody trained in hormones, who's been doing this for a long time. Because whenever I started looking up women's hormones and how to treat it, because I was interested in it, the thing that I kept coming across, the one thing I kept seeing was, you have to do hormones to understand hormones. And so it takes experience. There's no book out there. I mean, well, there's a million books out there on hormones. Let me rephrase that.
Yeah.
There's a
Yeah.
million books out there on hormones, but to treat hormones, you have to understand the person in front of you, and their full history, to really do it appropriately and understand that progesterone and estrogen and testosterone come in a million different varieties. And then you have DHEA and you have pregnenolone that can also be needed. And that's a totally different conversation.
Right. Yeah.
I start with the foundation of hormones and we build on that. So you have to have somebody that's willing to listen to you and not just say, if you ever get told it's part of life, just deal with it, or your hormones are fine and you don't feel fine, go find somebody else. Just don't get your feelings hurt. And if you ever get offered an antidepressant on top of that, definitely run.
Okay. Yep. All right. I love it. Natalie, thanks so much for coming on the podcast. Can you tell people where they could find you, and how to kind of get in contact with you?
Sure. I'm at Wellness MD in Collierville. We're off of Houston Levee, and we do more than just hormones. I mean, we really help patients with weight loss as well, and we do coaching sessions with them. We help upregulate gut health. We do a lot of alternative therapies for autoimmune disease and cancers, IV therapies. So it is the majority of what we do is weight loss and hormones, but we do a plethora more as well. So you can contact us at wellnessmd.com, I think is our website. And my name's Natalie Narrow, and we have some great clinicians there and health coaches that can help you through your health journey.
Awesome. Natalie, thanks so much for coming on the podcast.
Thank you.
All right, guys. We'll see y'all soon. Bye.
Thank you for listening to NBS Fitness Radio. If you enjoyed the podcast, be sure to share it with your friends, follow us on social media, and check out our website at www.nbsfitness.net. Hit the subscribe button and tune in next time for more NBS Fitness Radio.